Hello friends, now I'll be talking to you regarding glomerular diseases. There are certain questions which you have to do. Stop the video to answer the questions. This is question number 1. Read it, mark your answer. Here's the question number 2. Again read it and mark your answer. Well, the topic of discussion of today is minimal change disease. Right? So before I proceed to that, let's learn the basic concept about pathology of glomerular diseases. Okay, but before we discuss the pathology, you should know the normal histology. Unless you are clear about the normal histology, you will never understand the pathology. So normal histological examination of the glomerulus. This is the epithelial cell, and these are the foot processes. Epithelial cell, foot process, so-called podocyte. This is the glomerular basement membrane, GBM, and here is the capillary endothelium, and here is the capillary lumen. CL is lumen of the capillary where the blood is flowing, and here is you can see this cursor going on. This is a wall of the capillary which is facing toward the basement membrane, and it is this which has got pores, and the supporting cell is mesangial cell. And this is the mesangial matrix, which is the nothing but the supporting connective tissue. This is a normal histology. Now let's talk about pathology of the minimal change. In the pathology of minimal change, this is the epithelial cell having foot process. They are lost. Okay, so now you can see these foot processes have gone away, and with the result, it has become a flat. So what we classically call as loss of foot process or so-called fusion of podocyte. Fusion of podocyte, also known as effacement of podocyte, all are the same. But the point of importance is, if you look this into light microscopy, it totally looks normal. Whatever changes of what I said, loss of foot process, this you can see only in electron microscopy. And one more thing you may have noticed by now, there's no antigen antibody deposition is there. So this was the basic concept. I hope you are clear about the basic pathology. Let's move further. Let's talk more about the minimal change. Well, minimal change disease is the most common cause of nephrotic syndrome in children, classically in the age of 2 to 8. As I told you, in the pathology and the light microscopy, normal is a very important point that you should remember. And diffuse effacement of foot process of visual epithelial cell, so-called podocyte, and this I told you, this is seen classically in electron microscopy. Light microscopy is normal. Again, a point to be remembered. The Q means the point you have to remember it. Now, one more extra point that you got to remember. In the cells of proximal convoluted tubule, PCT, they are often laden with lipid and proteins, reflecting tubular reabsorption of lipoprotein passing through the diseased glomeruli. Thus, this is also known, previously it was known as lipoid nephrosis. we should understand what he's talking about. So let's learn basic concept about why and how lipid goes into the cells. So here is the nephron, Bowman capsule, and with these are the visceral epithelial cells. But at the moment, I'll be just drawing the tubular cells. These are tubular cells. We all know very well that proteins are filtered into the urine in nephrotic syndrome, and these cells, they try to reabsorb lipoproteins, which I'm mentioning here. These lipoproteins, they are reabsorbed, and ultimately they get accumulated in the cells of VCT. And as that means lipoproteins will be there, fat globules will be there. That's why we call as lipoid nephrosis. Okay. Well, immunofluorescence will be totally normal. And for normal, why? Because there is no antigen antibody deposition. Again, a very, very important point to be remember, right? So now same thing, I'm showing you a beautiful picture. These are the food processes have been lost and it has become flat. And these are the capillary endothelium. These are the pores. This blue structure is the glomerular basement membrane, and this is the capillary lumen where the blood is flowing. Okay. Let me show you one more diagram. This normal structure. Here, these are the food processes. Podocytes having food process, and in between the two podocytes, we have a very slit diaphragm is there. Now, again, very important point you have to understand right now. So this is the minimal chain disease. You can see the food process has been lost. But one more thing which most of students do not appreciate, when this food process get effaced, the slit diaphragm, this place, it becomes widened. That create more space because of loss of food processes. Okay, and it has a very important role to play. Why and how I'll be discussing in a couple of in one or two slides, after one or two slides. And now you can see that this slit space is widened, and this albumin, which is there in the capillary lumen, it filtered out from these pores and from this slit diaphragm, they filtered out. What's the mechanism? This I'll be discussing. But you, at the moment, you got to remember this slit diaphragm and, of course, loss of food process. So if I have to give you summary of pathology, light microscopy in minimal change will be total normal, N for normal. That means if you look into a microscope, light, nothing will be visible. And in electron microscopy, you will find this fusion of food process, which I mentioned to you, of food process or so-called food process or so-called effacement of the podocyte. Immunofluorescence, absence of immunoglobulin or complement, that means even immunofluorescence will be normal because there is no antigen antibody deposition. So no antigen antibody, that means even immunofluorescence will be normal. Now let us see what are the causes of minimal change. Majority of time, this is idiopathic. 90 to 95% cases, this is idiopathic. But rarely or uncommonly, this can be caused by certain drug like non-steroidal anti-inflammatory drug, rifampicin, interferon alpha. But a classical question of Usmle, it may occur in Hodgkin disease. Hodgkin, lymphoma or Hodgkin disease. This is a very, very important question that you got to remember. Q means point to be remembered. This may occur in HIV also. It can occur as in allergic reaction, so it can occur in atopy also. And uncommonly, it may occur due to upper respiratory tract infection also. URTI can be a cause in some cases. Now, important negative point to be remember. Hepatitis B and hepatitis C, they are not the cause. Why it is so important to talk? Because hepatitis B and C are very important cause of membranous and membranoproliferative membranoproliferative glomerulonephritis, so-called MPGN, but they do not cause minimal change. Now I have a question for you. Stop the video, write down the answer. This is a top rank getting question. The question is, usually, most of the time, minimal change get resolved of its own. But rarely minimal change can progress to some other glomerular disease. Stop the video, write down the answer. What is the name of that glomerular disease? Well, I'm sure by now you have written the answer. The answer is it can progress to focal and segmental glomerulosclerosis. Okay. I have recorded a separate lecture on FSGS, what is called as FSGS. So you can see that lecture also. Now let's talk about what is the basic pathophysiology, mechanism of proteinuria, pathophysiology. Well, as I told you, effacement of food process, so-called fusion of food process. This play a very important role in causing proteinuria. I hope you remember the histology. Now, why proteinuria occurs? First of all, these food processes, what I mentioned to you right now, okay? Food process, they are negative charge. And albumin is also negative charge. So these two negative charge particles are normal. So what happens? Both being negative particles, they tend to repel each other. That's why this albumin is not filtered. This is the food process. But once this food process is lost, now it has become like this. Effacement is there. And here is the albumin, negative charge. Now it has got no difficulty in moving out. And one more thing, okay, one more thing, I hope you remember that in this case, slit diaphragm was widened. So disruption of component of slit diaphragm also contribute, and in fact it is much better seen in congenital nephrotic syndrome of Finnish type. In that, the basic pathology is much widening of the slit diaphragm. And of course, loss of actin cytoskeleton also contribute to this problem. But this is the most loss of polyanion, that is loss of negative particle is the most important contributing factor of proteinuria. Now what are the clinical features? Typically occurs in 2 to 8 years, this you got to remember. And proteinuria is present in the nephrotic range, that is more than 3.5 gram per day. Because of massive proteinuria, the urine is frothy or foamy. Frothy. And the very important point is there is selective proteinuria is there. Now, what is the meaning of selective proteinuria? That means there is excretion or secretion of low molecular weight like albumin. And the big molecules like high molecular weight immunoglobulins, they are not there. That's why we call it selective proteinuria. But one more thing that most of people are not aware. Although when we talk about selective proteinuria means albuminuria, but very trace amount of IgG and alpha 2 macroglobulin can also be there in the urine. But remember, they are only trace amount, very minimal, not too much. By and large, selective proteinuria means albuminuria. BP is normal in this case. That means hypertension is not a feature. Edema, feet and puffy face, and there can be generalized anasarca can be there. Why? Let's learn the basic concept. Why? We all know very well. Here the blood vessel. In the blood vessel we have water. It tends to go out via hydrostatic pressure. In the blood vessel we have albumin. It tends to bring water inside via oncotic pressure. OP is oncotic pressure. So now, as in this case, albuminuria is there. So this will go out of the body. So oncotic pressure is reduced. So now hydrostatic pressure is more than the oncotic pressure. With the result, this more and more water will go out, and more water goes out, that lead to edema, feet, puffy feet, and anasarca. Water is going into third space. GFR is normal. That means renal failure is not a feature, and there is no significant any urinary sediment. That means if you examine the urine, you will not find any sediment, and hematuria is not a feature. It's not a feature. By and large, urine examination is normal. And one more good thing, the changes are reversible with the use of corticosteroid. CS stands for corticosteroids. Now, how you treat a case of minimal change disease? As I told you, main treatment is prednisolone is the main treatment. Corticosteroids. Most children, you can say around 95% cases of minimal change disease, they respond very well to steroid therapy. But there are few cases which do not respond. Then we may have to use some other immunosuppressive drug like cyclophosphamide and mycophenolate. Okay, but now when to use these drugs? Frequent relapses. That means you are giving steroid, but patient again go into relapse. Or you are giving steroids, okay, the moment you stop, they again come back. That means you have to give steroid to maintain the patient in a normal state. But sometimes there are few cases who do not respond, to call steroid resistant cases. Okay, now we have cyclosporin was used sometime in some cases. It can induce remission, but relapses is also common when cyclosporin is withdrawn, right? So now let me discuss about steroid resistant type of nephrotic syndrome. Steroid resistant, so-called SRNS, it occurs in those children who do not depend on traditional, who do not respond to traditional treatment of steroids. They are known as steroid resistant. And these include, we have to use other combination of drugs other than immunosuppressive drug, what I mentioned to you. But in this, we should also add ACEI or ARB. that is angiotensin receptor blocking drug or angiotensin converting enzyme inhibitors. They reduce proteinuria in these cases. So a quick recap of the last minute revision point: nephrotic syndrome in a child of 2 to 8 years, selective proteinuria, loss of food process is seen in electron microscopy. Now let's discuss the questions which you have done. So in the question number 1, most likely cause, most likely to be both abnormal and useful in diagnosis of this condition is, the answer is D. Okay, let's discuss the question now. So by now, so what are the keywords in this question? The keywords is 6-year-old boy. I told you the common age of minimal change is 2 to 8 years. Stung by bee, generalized urticaria, that means it is due to atopy, and atopy is a inducing factor for minimal change. Foamy urine, protein in the 4.5, that means he's in the nephrotic syndrome range. NS is nephrotic syndrome, and when there's massive proteinuria, urine is foaming, I discussed. So by and large, we are, so in nutshell, we are getting one child which has been induced nephrotic syndrome and due to atopic reaction. So 2 to 8 years, minimal change disease is the most likely cause. And just to remind you, minimal change disease can be induced by respiratory tract infection, some immunization, or in this case is atopy, as urticaria is there and bee stung, it is stung by the bee. So now it's very clear that we are dealing with a case of minimal change, and in this case electron microscopy will be abnormal. Definitely there is loss of food process, and this you can see only with electron microscopy. Now let's look into other option. Option A, serum creatinine and BUN, they are normal in a case of minimal change disease. So there is no role of creatinine and BUN. There is no azotemia. Option B, light microscopy, sample will be normal, so it has got no role, I discuss. Similarly, immunofluorescence will be normal. Why? There is no antigen antibody deposition, so it will be normal, so there is no role. So now you are, and what about option E, which is talking about urinary sediment? There are no urinary sediment, that means it has got no role in helping diagnosis. Let's talk about question number 2. Which the following pathological changes is more likely to be seen in this case? Protein loss. Let us see. The answer is podocyte. The key word in this, and loss of podocyte is seen in minimal change disease. Now let us see what the child has. 5-year-old child, generalized edema, upper respiratory infection, BP normal, heart rate normal, creatinine normal, proteinuria, no hematuria, selective proteinuria. These words itself are sufficient to tell you that's a case of minimal change disease, and there is loss of podocyte. These words itself are self-explanatory. However, we'll discuss other questions. So now in this case, upper respiratory tract infection has led to minimal change disease. Option A, crescent formation. This is not a feature of a minimal change disease. This is seen in RPGN, rapidly progressive glomerulitis. I have recorded a separate lecture for that. You must see that lecture also. Okay, and RPGN present as renal insufficiency, it can go into chronic renal failure. And in this case, there is no renal failure in our question. Kidney function is normal. Thinning of glomerular basement membrane. This is seen in basement membrane nephropathy as well as Alport syndrome. And in this case, microscopic hematuria is seen in our question. There is no hematuria. And Alport syndrome is an inherited defect in the formation of collagen 4. And in this case, hematuria, progressive renal failure and hearing loss and ocular abnormalities are there. Option D is incorrect. Tubular necrosis and epithelial shedding is not a feature. This is seen in acute tubular necrosis, which is occurred due to acute renal failure. and in this case there is damage to tubular cells, basement membrane, also tubulorexis is there, and it does not manifest as loss of food process. Food process loss is not a feature. Nodular sclerosis, this is seen in long-standing diabetes. Of course, these are known as KMW lesion are seen. But and of course, one more thing, although diabetic nephropathy may present as nephrotic syndrome, typical patient are elderly people. But a patient of our question is just a child of 5 years. So this is not a case, and of course, there is no history of diabetes. So now the last golden line to remember: this a child of 2 to 8 years, nephrotic syndrome with selective proteinuria is minimal change. This the entire minimal chain disease has been squeezed in one line. Okay. Thank you very much for watching this.